So let me first introduce myself. My name is Ahmed. I'm a medical grad from Egypt. I passed my step 1 and my step 2 CK exams with 261 score. I've been tutoring for 3 years now. I helped lots of students pass their step 1 and the step 2 CK exams. I became ECFMG certified a couple of months ago, and I'm applying for this year's match cycle. So before we start our session, make sure to download our free high-yield files using the links that will be posted in the comment section right now. They are completely free, and they will make a great review before your exam, guys. And if you are looking for a more personalized tutoring or more personalized help, we also offer one-on-one tutoring. All our tutors are 260 plus tutors, okay? And the one thing that differentiates us from other companies is we already offer a 30-minute demo session. It's completely free, okay? To see if you are like the right fit with this tutor or not. And if you prefer courses, we already offer our step 1 and the step 2 CK crash courses. Each course is 7 days. Each day we are hammering down the high yield concepts, 10 hours each day, okay? So 70 hours of tutoring total. We also offer our Synapse QBank for step 1 and step 2 CK. So both of them are around 1,300 questions, again, focusing on the high yield stuff. So if you don't have time or you want to focus on the high yield stuff before your exam, also check this out. We already offer 40 questions for free. Okay, guys? So without any further delay, let's start our session. All right, can you guys see my screen right now? Okay. So in today's session, we will focus on the diseases with autoantibodies. This is super important, okay? So it's very important to know the presentation of each condition and what is the autoantibody associated with this condition. After that, we will move on to the high-yield interleukins that I'm positive that they are very important and they always show up in the exams. And after that, we will go over some questions from our Synapse QBank. So let's start our session. Let's start with this question. We have a 28-year-old woman presenting with fluctuating ptosis and diplopia that is worsened throughout the day and improve with rest. Repetitive nerve stimulation shows decremental response. Which autoantibody is most likely responsible for this presentation? Amazing, guys. So decremental response meaning it's decreasing. So which muscle weakness has decremental response to repetitive nerve stimulation? The myasthenia gravis. Amazing, guys. So myasthenia gravis is basically a disease in which we will have autoantibodies against postsynaptic acetylcholine receptors. So we call this part between the nerves and the muscle the synapse. Okay. And the nerve will start releasing the acetylcholine in this synapse, and then the acetylcholine will bind to the postsynaptic acetylcholine receptors. So if we have autoantibodies against the postsynaptic acetylcholine receptor, this will cause muscle weakness that's called myasthenia gravis. And you need to know that this myasthenia gravis can be associated with a tumor in the anterior mediastinum. We call this tumor thymoma. Excellent. So if he gives you a question, we have a patient presenting with muscle weakness, and on CT scan of the chest, we found a mass in the anterior mediastinum. He's talking about myasthenia gravis associated with thymoma. Okay, nice. So what about autoantibodies against presynaptic calcium channels? Presynaptic calcium channels. Obviously, this will also cause muscle weakness. We call this disease Lambert-Eaton myasthenic syndrome. Okay, it's a muscle weakness, but it's a bit different than myasthenia gravis. In myasthenia gravis, we mentioned that it will improve with rest. In Lambert-Eaton, the muscle weakness improves with use or with exercise, with running, okay? And on repetitive nerve stimulation, we will have incremental response, increasing response. All right. Since myasthenia gravis is associated with a tumor, also Lambert-Eaton myasthenic syndrome will also be associated with a tumor. This tumor is a mass in the lung, in the center of the lung. This is small cell lung cancer. Okay. So if he tells you we have a patient presenting with proximal muscle weakness, and this patient had a 40-year smoking history. I swear, guys, this is enough to diagnose Lambert-Eaton myasthenic syndrome sometimes. Okay, so a smoking history, 40-year smoking history, plus proximal muscle weakness, this diagnoses small cell lung cancer associated with Lambert-Eaton syndrome. All right. So a 65-year-old man with a smoking history and the muscle weakness that improves with repeated muscle use. Which autoantibody explain this weakness? Amazing, guys. As we mentioned, this is Lambert-Eaton myasthenic syndrome, and it's basically autoantibodies against the presynaptic calcium channels. Presynaptic calcium channels. Excellent. We have a 30-year-old woman with a history of 2 prior miscarriage with a swollen, painful left leg. PTT is prolonged and doesn't correct with mixing study. Which autoantibody is most likely associated with this presentation? Amazing, everyone. Excellent. Amazing. So we have a patient presenting with prior miscarriage and a DVT. And we have a very, very weird finding. He's saying that the PTT is prolonging. How the hell the PTT is prolonging? In prolonged PTT, I expect bleeding, not thrombosis. We call this paradoxical increase in PTT. And this is a specific finding that can happen with antiphospholipid antibody syndrome. Okay. And why would this patient have elevated PTT level? Why would this patients have paradoxical increase in the PTT? Because one of the autoantibody associated with antiphospholipid syndrome. What do we call this antibody, guys? What do we call the antibody that can cause paradoxical increase in PTT? Nope. Not cardio-11, no. Amazing, Muhammad. Amazing, Kushi. Excellent, guys. Excellent, Saro. Okay, so we call it amazing. So we call it anti lupus anticoagulant. Okay, so this is the autoantibody associated with high PTT. We have also a very weird finding in patients with antiphospholipid antibody syndrome, which is false negative, or sorry, false positive VDRL and RPR. These are the tests for syphilis. I know that most of you guys, when you see positive VDRL or positive RPR, you think of syphilis. But we have another disease in the USMLE that can cause false positive VDRL and RPR, which is the antiphospholipid antibody syndrome. And what is the cause of the false positive VDRL and RPR, guys? What is the cause of the false positive VDRL and RPR? Anti-cardiolipin antibody, the one that you just mentioned. Okay, anti-cardiolipin antibody. Amazing. So the correct answer here is anti-beta-2 glycoprotein 1. So now we have 3 antibodies associated with antiphospholipid syndrome: the anti-beta-2 glycoprotein, the anti-cardiolipin, and the anti-lupus anticoagulant. Is that clear, everyone? Kushis, this is exactly what we are saying. This autoantibody is causing the false positive or the paradoxical increase in the PTT. okay? But the disease itself causes coagulation and causes thrombosis. That's why we call it paradoxical increase. It is the opposite of how the disease presents. You get what I'm saying? Okay. So we have a 24-year-old woman presenting with facial rash, oral ulcers, arthralgia, and new onset proteinuria. Renal biopsy shows immune complex deposition. Which autoantibody are most specific for this diagnosis? Amazing, everyone. So this is the classic presentation of SLE. These patients can present with the malar rash, which is the rash that is not involving the nasolabial folds. They can also presenting with painless oral ulcers, arthralgia, and proteinuria. And whenever they have renal involvement, it means that they will have positive anti-double-stranded DNA. So anti-double-stranded DNA is a specific autoantibody for SLE, especially if the SLE involves renal damage, okay? What other autoantibody is associated with SLE, guys? No, not ANA. ANA is not specific for SLE. Amazing. So the one that is also specific for SLE is anti-Smith antibody. So anti-Smith antibody, anti-double-stranded DNA antibodies, both of them are specific for SLE. Amazing. We have a 55-year-old man develops rash, arthralgia, fatigue 2 months after started new anti-arrhythmic medication. The symptoms resolve after the drug is discontinued. Which autoantibody is most associated with this presentation? Amazing, everyone. So this is called drug-induced lupus. The patient will start a medication, and after that, he will have the symptoms similar to SLE. And the autoantibody specific for drug-induced lupus is antihistone antibody. Now, can someone tell me what is the antiarrhythmic he's talking about here? The antiarrhythmic that will cause drug-induced lupus. Excellent, Carol. Amazing, Fisiha. Excellent, Sarah. No, not amiodarone. Amazing, everyone. So the medication he's talking about here is procainamide. Okay, which is the treatment that can be given in patients with WPW, Wolff Parkinson White syndrome. Okay, nice. Now, what other medications can also cause drug-induced lupus? For example, isoniazid. You remember the TB medication that can cause vitamin B6 deficiency? It can also cause drug-induced lupus. Also, hydralazine, which can cause arteriodilation. That's why it can be given in patients with hypertension, especially if the patient is pregnant, okay? Also, sulfa medications, it can cause also drug-induced lupus. We also have PTU and methimazole. These are the antithyroid medications. They can be given in case of hyperthyroidism. They can also cause drug-induced lupus. Amazing. Also anti-TNF alpha medications and all of this. All right, guys, be familiar with these examples. We have a 29-year-old woman presenting with episodic color changes in her fingers, turning white, then blue, then red. What do we call this? Raynaud's phenomena. Okay. She also reports ulcers at the tips of her fingers. Also, the patient is having proximal muscle weakness with symmetric joint pain. Which autoantibody is specific for this presentation? Now, this presentation is a bit crazy. So you are telling me that this patient is presenting with Raynaud's phenomena and the ulcers of the tip. Okay, so now you will make me think of the crest syndrome, and these ulcers are the calcaneus cutis. But then you are telling me that we have proximal muscle weakness. So you will make me think about polymyositis. And now you are telling me that we have symmetric joint pain. You will make me think about the rheumatoid arthritis. What is this? So we call this mix of the rheumatoid arthritis, polymyositis, and the scleroderma. This disease is called mixed connective tissue disease. Okay, mixed connective tissue disease. This is literally how you diagnose it in a question. You will read a line and you will say this is rheumatoid arthritis. The second line would be scleroderma. The third would be polymyositis or dermatomyositis. Okay, so what is the autoantibody specific for the mixed connective tissue disease? Amazing, guys, as you said, the anti-U1 RMP. Okay, anti-U1 RMP. Again, like the disease itself is mixed and the autoantibody looks mixed. It is just a bunch of letters and one number, anti-U1 RMP. All right, so be familiar with that. No, it can't be scleroderma or Crest syndrome. Okay, we have some symptoms of the Crest syndrome, but what about the other ones? Okay, the symmetric joint pain, is it symmetric? No. The muscle weakness with elevated creatinine? No, this doesn't happen in Crest syndrome. Okay. So we have a 52-year-old woman presenting with dry eye, dry mouth, and bilateral parotid gland swelling. She reports difficulty swallowing dry food. Which autoantibody are most associated with this condition? Amazing, guys. Excellent. We call this the Sjogren syndrome. And what are the autoantibodies specific for Sjogren syndrome? I always remember that the female patient affected with Sjogren is called Rola. Her name is Rola. This will make me remember the autoantibodies of Sjogren. So we have the anti-Ro antibodies and the anti-La antibodies. Anti-Ro and anti-La. Sometimes he might mention the other names for them, which is called SSA and SSP. Again, they make sense. Like the first part of the name, Ro, will be A. The first part is A. And the second part would be B. Exactly. Amazing. All right. I have a question for you guys. Let's say that you had a patient with a known history of Sjogren presenting to you with unilateral enlargement of one of the parotids. What's happening to this patient? Okay, again, you had a presentation of a patient with known history of Sjogren, and she's presenting now with unilateral enlargement of the parotids. Unilateral. Amazing, guys. This patient is presenting with B-cell lymphoma. Which one of lymphoma, guys? Which lymphoma is associated with chronic inflammation? The multi-lymphoma. Okay. Multi-lymphoma. So again, the presentation would be a patient with known history of Sjogren presenting with unilateral enlargement of the parotid. Be familiar, guys, that multi-lymphoma can also happen in the stomach secondary to H. pylori. Amazing. H. pylori. Very, very important. Okay. We have a 48-year-old woman presenting with symmetric swelling and pain in the MCP and PIP. And she also have morning stiffness lasting over an hour. Which autoantibody is most specific for her likely diagnosis? Amazing, guys. Excellent. So this is a classic presentation of rheumatoid arthritis, a female presenting with symmetric joint pain and also stiffness in the morning that is more than 30 minutes. It's very important that it should be more than 30 minutes because less than 30 minutes, it can also be osteoarthritis. So which autoantibody is specific for rheumatoid arthritis? Anti-CCP. Okay, anti-CCP. This is the one specific for rheumatoid arthritis. What about rheumatoid factor, guys? It is not specific. Rheumatoid factor can be positive in patient with SLE, patient with Sjogren. Exactly, it is sensitive, but it is not specific. All right? What about ANA? It is not even positive in patient with rheumatoid arthritis. Not even, no, not even positive in patient with rheumatoid arthritis. It can be positive in other autoimmune conditions, yes. Okay, amazing. Okay, a 45-year-old woman presenting with diffuse skin thickening involving the trunk and proximal extremities. Pulmonary function test reveals restrictive pattern consistent with interstitial lung disease. Which autoantibody is most associated with this diffuse form of her disease? Amazing, guys. So this patient is presenting with skin thickening, no wrinkles, and also with fibrosis in the lung. So fibrosis all over the skin and the fibrosis in the lung. This diagnosis diffuse scleroderma. And what is the autoantibody specific for diffuse scleroderma? Anti-scleroderma 70. Okay, anti-scleroderma 70. Its other name is anti-DNA topoisomerase 1. Okay, anti-DNA topoisomerase 1. So that sometimes he might use this name. A 40-year-old woman presenting with proximal muscle weakness, elevated creatinine, and interstitial lung disease. He also has the mechanic's hand. Which autoantibody is associated with this syndrome? What is the diagnosis here, guys? Amazing, Tanya. Excellent. So this patient is presenting with dermatomyositis. These patients will have proximal muscle weakness and skin affection, dermato. So, for example, they might present with heliotrope rash, which is a rash at the eyelid, Guttrum papule at the knuckles, and the mechanic's hand. And what are the autoantibodies specific for dermatomyositis or polymyositis? Anti-Jo1 antibody and anti-Me2 antibodies. Okay, anti-Jo1 and anti-Me2. They sound very stupid, guys, but you need to memorize these stuff. Okay. All right. A question for you guys. Let's say that you confirmed the diagnosis of dermatomyositis. What would be the best next step you should do to this patient? So now we know she's having dermatomyositis. What is the best next step? Amazing, guys. Cancer screening. Age appropriate. Cancer screening. Okay. These patients will probably have a cancer somewhere, most commonly in the ovaries. Okay, most commonly in the ovaries, but it can be anywhere else. So the best next step after the confirmation is age-appropriate cancer screening. Amazing. A 50-year-old woman presenting with episodic color changes in her fingers, white, blue to red. So again, this is Raynaud's. She has thickened, tight skin limited to her fingers and face, along with small dilated blood vessels visible on her skin. We call this telangiectasias. So which autoantibody is most associated with this presentation? Excellent, guys. So we call this condition CREST syndrome. The C is for the calcinosis cutis, which is the ulcerations at the tips of the fingers. Okay, these ulcerations are calcified. That's why they are named calcinosis cutis. The C is also for centromere, which is the autoantibody associated with CREST syndrome, anti-centromere antibody. The R for Raynaud's phenomena. E for esophageal dysmotility. This patient will have dysphagia. Why? Because of the fibrosis inside the esophageal muscles. The esophageal muscle can't contract. The S for sclerodactyly, which is basically fibrosis limited to the fingers, sclerodactyly. And the T for telangiectasia, which are the small dilated blood vessels in the skin. So this is how the presentation of limited scleroderma, or its other name, CREST syndrome, and the autoantibody associated with it is anti-centromere antibody. Okay, but anti-scleroderma 70, don't forget, this is for the diffuse scleroderma. Very important. Okay, we have a 60-year-old woman presenting with pruritus, fatigue, and jaundice. Labs show markedly elevated alkaline phosphatase. Which autoantibody is associated with her diagnosis? Nice. Amazing job. All right, so we have a female presenting with jaundice and pruritus. And he's saying that we have elevated alkaline phosphatase. By the way, elevated alkaline phosphatase, it means we have a pathology either in the bone or in the bile ducts. But if he's mentioning a jaundice with it, obviously he's talking about the bile ducts, right? So this is a classic presentation of primary biliary cholangitis. Primary biliary cholangitis, which is basically a granulomatous disease attacking or affecting the intrahepatic bile ducts. Okay, granuloma or granulomatous disease affecting the intrahepatic bile ducts. That's why these patients can present with the jaundice and the pruritus because of the bile acids under the skin. So what are the autoantibody associated with primary biliary cholangitis? Anti-mitochondrial antibody. Again, the name looks weird. Anti-mitochondrial in a bile duct disease. Please memorize it, okay? Anti-mitochondrial antibody. Okay. So we have another autoantibody in the USMLE that is similar to anti-mitochondrial antibody called anti-microsomal antibody. I'm just mentioning it because I know lots of students who mix them up. So what is anti-microsomal antibody, guys? This is the same as anti-thyroid peroxidase antibody. And we know that anti-thyroid peroxidase is autoantibody associated with Hashimoto's thyroiditis. Okay, so please don't mix them up. Antimitochondrial for primary biliary cholangitis, antimicrosomal for Hashimoto's thyroiditis. Okay. All right. A 35-year-old man presenting with jaundice and elevated alkaline phosphatase. He has a history of bloody diarrhea. Which autoantibody is most associated with this presentation? Amazing, everyone. Excellent. So we have a male patient presenting with jaundice and a history of bloody diarrhea. We only have one disease in the USMLE that can present like this, the primary sclerosing cholangitis. Primary sclerosing cholangitis, which is basically fibrosis in the intra and the extrahepatic bile ducts. Okay, so this is a disease affecting the hepatic bile ducts. Okay, and it makes sense that the patient will present with jaundice. But why the patient will present with bloody diarrhea? It looks very weird. Because primary sclerosing cholangitis is associated with a history of ulcerative colitis. Okay, he doesn't have to tell you that this patient is having a history of ulcerative colitis. He might tell you that the patient had episodes of bloody diarrhea and fever. Okay, it gives the same meaning. So what is the autoantibody associated with primary sclerosing cholangitis or ulcerative colitis? P-ANCA. Okay, P-ANCA. This is the autoantibody associated with PSC or ulcerative colitis. And can someone tell me this autoantibody is directed against which cells in the body? Guys, all the autoantibodies will be mentioned. Okay, amazing. It's called anti-neutrophil cytoplasmic antibody. Anti-neutrophil cytoplasmic antibody. So these are autoantibodies against the neutrophils. Amazing. A 22-year-old woman presenting with fatigue and jaundice. Lab shows AST and ALT greater than 1,000. Liver biopsy shows dense lymphocytic infiltration. Which autoantibody is most likely associated with this condition? Amazing, guys. Excellent work. So this patient is presenting with autoimmune hepatitis. So I thought about the autoimmune hepatitis because, first of all, it is one of the causes of high AST ALT more than 1,000. And also because of the lymphocytic infiltration. We have the T cells attacking the liver, so we will have lymphocytic infiltration. So what autoantibody is specific for autoimmune hepatitis? Anti-smooth muscle antibody. Okay, anti-smooth muscle antibody. This is the one that is specific for autoimmune hepatitis. Again, it looks very weird. We are talking about the liver, and the name is anti-smooth muscle antibody. Just memorize it for the exam, okay? Now I have a question for you guys. Can someone tell me the other causes of elevation of AST and ALT more than 1,000? Amazing. Excellent, Carol. Acetaminophen, toxicity. We expect these patients to have high AST and ALT more than 1,000. Also, in case of acute hepatitis, hepatitis A or B, acute hepatitis A or B, these patients can present with AST and ALT more than 1,000. Or in case of ischemic hepatitis. So, for example, he will tell you that we have a patient who just had a severe trauma that results in hemorrhage, and now he's hypotensive. After some time, the patient had a right upper quadrant pain and AST ALT more than 1,000. This is the presentation of ischemic hepatitis due to hypoperfusion. Okay, amazing. Sepsis elevates it, yes, because sepsis will also cause hypoperfusion to the liver because it's a shock. So this is ischemic hepatitis also. A 58-year-old man presents with hemoptysis, sinusitis, and hematuria. Biopsy of the nasal lesions shows granuloma. Which autoantibody is most associated with this presentation? Amazing, everyone. Excellent. So here we are talking about the Wegener's vasculitis, which is a small vessel vasculitis affecting the lung, causing hemoptysis, affecting the upper airways, causing the sinusitis or nasal ulceration, or even otitis media, and affecting the kidney, causing the hematuria. So what is the autoantibody associated with it? C-ANCA. Okay, this is the only condition that is associated with C-ANCA in the USMLE. And again, guys, C-ANCA is autoantibody against which cells? The same. So neutrophils. Okay, so C ANCA, P ANCA, I don't care. Both of them are anti-neutrophil cytoplasmic antibodies directed against the neutrophils. Exactly. Okay. So C is also cytoplasmic anti-neutrophil cytoplasmic antibody. Okay. I really don't know P ANCA. Can someone tell me what is P stands for? Okay, Tanya is saying proteinase. Yeah, yeah, perinuclear. Yes. Yes, peri. I remember that now. Okay. A 50-year-old man presenting with new onset lower extremity edema and the proteinuria in the nephrotic range, more than 3.5. Renal biopsy shows diffuse capillary and basement membrane thickening without significant proliferation. Which autoantibody is most associated with this presentation? Amazing, everyone. Excellent. So this patient with nephrotic syndrome is presenting with primary membranous nephropathy. Primary, okay? And the primary membranous nephropathy is associated with antiphospholipase A2 receptor, okay? Antiphospholipase A2 receptors. What about secondary membranous nephropathy? Membranous nephropathy can happen secondary to what, guys? What are the triggers that can cause the membranous nephropathy? Nice, Sarah. So we have the hepatitis C, hepatitis B, okay? Solid tumors. Nice. Gold and penicillamine. Penicillamine is a medication that can be given in Wilson disease. Okay. So this is very important. Also, SLE, like SLE can cause either nephrotic or nephritic. If it causes nephrotic, it is due to membranous nephropathy. Okay. Nice. So be familiar with these examples, guys. Okay. These are super important examples that were mentioned in the questions in different QBanks before. We have a 70-year-old woman presenting with tense polio on her trunk and extremities. Skin biopsy shows subepidermal blistering without acantholysis. Which autoantibody is most associated with this condition? So this disease is bullous pemphigoid, and it's caused by autoantibodies against the hemidesmosomes. These are proteins attaching the epidermis to the dermis. So if we have autoantibodies against them, the epidermis will start separating from the dermis, and we will have a blister between them. And if you notice, the roof of this blister would be the whole thickness of the epidermis. And that's why this blister is very tense. It is not easily ruptured. That's why these blisters are Nikolsky negative. And the bullous pemphigoid is the only blistering condition that is Nikolsky negative in the USMLE. Okay, amazing. We have a 55-year-old man presenting with painful, flaccid oral and skin blisters that rupture easily. Nikolsky sign is positive. Obviously, like the blister can rupture easily, so this is Nikolsky positive. Skin biopsy shows intraepidermal acantholysis. Which autoantibody is most associated with this condition? So this is a presentation of pemphigus vulgaris. Pemphigus vulgaris is basically autoantibodies against the desmoglein, which is the protein forming the desmosomes. These are proteins between the keratinocytes of the epidermis. They help attach the keratinocytes together. So if we have autoantibodies against the desmosomes, the keratinocytes will start separating. We call this acantholysis. And since the keratinocytes are separating from each other, they can form blisters, and these blisters would be very weak, very placid. Okay, that's why pemphigus vulgaris blisters are Nicoleski positive. Okay, Nicoleski positive. They can rupture easily on lateral pressure to them. Okay, amazing. Guys, we have a dermatology webinar. If you want to go through the dermatology stuff, you can check our YouTube channel. Okay. Yeah, everything is mentioned about the like pemphigus and the bullous pemphigoid, right? So we just need to focus on the autoantibodies. Okay. A 40-year-old woman presenting with fatigue, cold intolerance, and firm, non-tender, enlarged thyroid gland. The TSH is elevated. Which autoantibody is most associated with this condition? So this patient is presenting with symptoms of hypothyroidism plus high TSH. This tells me that this patient is having primary hypothyroidism. So the pathology is in the thyroid itself. And what is the most common cause of primary hypothyroidism, guys? Hashimoto's. Okay. So what is the autoantibody specific for Hashimoto's, as we mentioned? The antithyroid peroxidase antibody. Okay. Its other name is the antimicrosomal antibody, as we mentioned. And I have a question for you guys. Can someone tell me which type of hypersensitivity is Hashimoto's thyroiditis? So this is what I expected. Most of you said type 2 because we have like autoantibodies, and autoantibodies, this is type 2 hypersensitivity reaction. But no, Hashimoto's is type 4 hypersensitivity reaction. And why is that? Like type 4, and you are telling me we have autoantibodies? Yes, this autoantibody is just a finding. It is not the cause of the destruction. The destruction of the thyroid in Hashimoto's is caused by T cells attacking the thyroid. Okay, and antithyroid peroxidase is a finding in these patients. And it makes sense when you know that the histologic picture of thyroid in patients with Hashimoto's will show lymphocytic infiltration. So yeah, obviously the T cells are attacking the thyroid and they will infiltrate the thyroid, lymphocytic infiltration. Okay. No, it's not type 2 and 4, it's type 4. Okay. All right. A 32-year-old woman presenting with heat intolerance, weight loss, palpitation, and bilateral exophthalmos. Which autoantibody is most associated with this condition? Amazing. So this is a classic presentation of Graves' disease, the hyperthyroidism and the exophthalmos. And what antibody is specific for Graves'? The anti-TSH receptor antibody. So patients with Graves, they have autoantibodies or immunoglobulin similar to the TSH. So they will start binding to the TSH receptors on the surface of the thyroid, and this will activate the thyroid to release lots of thyroxine, causing the hyperthyroidism. And what is the autoantibody? What is the type of hypersensitivity of Graves' disease, guys? Amazing. This is type 2 because the immunoglobulin is causing the pathology. Okay, it is not a finding. It is really causing the pathology here. Amazing. A 12-year-old boy presents with polyuria, polydipsia, and unintentional weight loss. He has a history of vitiligo. Which autoantibodies are most associated with this condition? Amazing. So this is a classic presentation of type 1 diabetes mellitus, polyuria, polydipsia, weight loss, and a history of other autoimmune condition, the vitiligo. So what autoantibody is specific for type 1 diabetes mellitus? Anti-glutamic acid decarboxylase antibody. Anti-glutamic acid decarboxylase antibody. And again, guys, can someone tell me what type of hypersensitivity is type 1 diabetes mellitus? Type 4 hypersensitivity reaction. So again, this autoantibody is just a finding. But what is really causing the pathology is T cells attacking the pancreas. And that's why the histologic picture of the pancreas in patient with type 1 diabetes mellitus is lymphocytic infiltration of the pancreas. Amazing. A 6-year-old boy presenting with fatigue and intermittent abdominal bloating. His parents note bowing of his legs. Hemoglobin is also low. Which autoantibody is most associated with this presentation? Okay, so we have a young boy presenting with abdominal symptoms, which is the bloating and all of this, plus bowing of the legs, which points towards vitamin D deficiency, and also hemoglobin is low, which points towards iron deficiency anemia. So all of this points toward a condition called celiac disease. Amazing. Celiac disease. So what is the autoantibody associated with celiac disease? Anti-tissue glutaminase antibody. Also, we have another antibody that is specific to it, which is called anti-endomysial antibody, okay? Or anti-gliadin antibody. So anti-tissue transglutaminase and anti-endomysial. Be familiar with these two. These are mentioned in lots of questions. And let's say that we have a patient, like he's having the same presentation, and then he tells you that this patient also have painful physicals at the elbows and knees. What's happening to this patient? Exactly. So we have a skin condition associated with celiac disease called dermatitis herpetiformis. Okay, herpetiformis, similar to the herpes, painful physicals. Okay, and the treatment for this condition is the same treatment as celiac disease. Avoid the gluten, and also you can give a medication called the dapsone. Okay, so dapsone can be given as a treatment for dermatitis herpetiformis. A 65-year-old woman presenting with fatigue, glossitis, abdominal bloating, and paresthesia in her feet. Which autoantibody are most associated with this condition? Amazing, guys. So a patient presenting with abdominal symptoms and paresthesia in her feet, and also he might tell you that the hemoglobin is low. This is the presentation of pernicious anemia, which is caused by anti-parietal cells antibodies or anti-intrinsic factor antibody. Okay, so we have autoantibodies attacking the parietal cells of the stomach, which are the cells that secrete the intrinsic factor. Or we have autoantibodies attacking the intrinsic factor itself. Amazing. A 24-year-old man presenting with hemoptysis and hematuria. Renal biopsy shows crescentic glomerulonephritis with linear IgG deposition. Which autoantibody is most associated with this condition? Amazing. So a male patient who is probably a smoker, presenting with hematuria and hemoptysis. This is the presentation of good pasture syndrome. In good pasture syndrome, we have autoantibodies attacking the basement membrane of the lung or of the alveoli and the basement membrane in the kidney. That's why the patient will present with hemoptysis and hematuria. Okay. Sometimes he might not mention anti-glomerular basement membrane. He will tell you that this patient is having anti-collagen type 4 antibody. So be familiar that the basement membrane in the lung or the kidney is made out of type 4 collagen. Type 4 collagen, okay? And can someone tell me what is the condition that is caused by mutation in type 4 collagen? Mutation, not autoantibodies. Exactly, guys. Alport syndrome. Nice. All right, so these are the tables for the autoantibodies that we mentioned today. Now let's go on and finish our session with the high-yield interleukins. Let's start with this question. A 68-year-old man is brought to the emergency department with fever, hypotension, and altered mental status. Blood pressure is high. Blood pressure is super low. And he's saying that we have elevated lactate and white blood cells. Which cytokine is most responsible for this patient hemodynamic instability? So this presentation with hypotension and fever, it looks like septic shock. And what is the cytokine that is responsible for the hypotension in case of septic shock? The TNF alpha, which is one of the pro-inflammatory cytokines. So TNF alpha, guys, is very, very, very important for the step 1 exam. You need to know that it mediates the hypotension in case of septic shock. It also mediates cachexia or cachexia in patients with cancer. So if he gave you like a patient with cancer, he has severe weight loss, and ask you what is the cytokine responsible for this, the answer would be TNF alpha. Also, TNF alpha is important for the maintenance of the granuloma. And we know that the granuloma is important for the immunity against the TB. So if a patient is going to start one of the TNF alpha inhibitors, like the infliximab, adalimumab, or etanercept, before the patient is going to start any of these medications, you must screen for TB. Why? Maybe the patient is having a latent TB inside of his body. And when you give the TNF alpha inhibitors, you will stop the granuloma formation. And now the TB will start disseminating in all the body. So before starting any of these medications, screen for the TB. And if the patient is having latent TB, treat the latent TB before starting the TNF alpha inhibitor. Is that clear, everyone? Okay. So we have a 45-year-old woman presenting with rheumatoid arthritis, and she started on a biological medication. Several weeks later, she develops low-grade fever, night sweats, and a productive cough. Chest imaging reveals cavitary lesions, so this patient is probably having like active TB. Which of the following medication did this patient most likely start? Exactly. So this is the thing that we didn't want. This patient had activation of her TB because she probably started one of the TNF alpha inhibitors, like the adalimumab. And after that, she had the active TB again. A 4-year-old boy has a history of recurrent bacterial, skin, and lung infections since infancy. Physical examination revealed delayed separation of the umbilical cord and the skin abscesses without pus. Deficiency of which of the following cytokine is most likely the explanation of this presentation? CPD, the session will be posted in 2 days on our YouTube channels, okay? All right, so this looks like leukocyte adhesion deficiency, okay? But we don't have the answer for it. We usually expect the CD18 deficiency as a correct answer in this condition, but we don't have this. So in order for the neutrophils to get out of the blood vessels and go to the inflammation site, we need to have chemotactic agents. Okay, chemotactic agents. What are the chemotactic agents? These are cytokines that pull the neutrophils into the inflammation sites. And what are examples for the chemotactic agents? Interleukin 8, C5a, and leukotriene B4. I always remember that 4, 5, 8 calls neutrophils to eat. So 4 is for leukotriene B4, 5 is for C5a, and 8 for the interleukin 8. So if the patient is having a deficiency in one of these, the neutrophils won't be able to get out of the blood vessel and go to the inflammation site. Okay, like this patient, for example. So this patient is having a deficiency in leukotriene B4. Amazing. A 30-year-old man presenting with fever, weight loss, and night sweats. Chest imaging shows multiple pulmonary nodules, and the imaging of the liver and the spleen shows innumerable small lesions. Genetic workup reveals a mutation resulting in deficiency of interleukin 12. Supplementation with which of the following would most likely improve this patient condition? You guys are amazing. Excellent. All right. So in order for the body to form or to make the granuloma, we must have the macrophages. And these macrophages will start releasing the interleukin 12. The interleukin 12 will activate the T helper 1, and after the T helper 1 is activated, it will release the interferon gamma, which will activate the macrophages. And this is basically the granuloma. Granuloma is a bunch of activated macrophages, okay? So if the patient is having an interleukin 12 deficiency, this step will stop and the body won't be able to form the granuloma. That's why he will start having disseminated TB to his lungs, to his liver, to his spine. But if you give this patient interferon gamma from outside, the interferon gamma will activate the macrophages directly without this step. We don't need this step anymore if you give the interferon gamma from the outside, because the interferon gamma will activate the macrophages and the body will start making the granuloma again. Okay? And that's why supplementing this patient with interferon gamma will improve his symptoms. Is that clear, everyone? Amazing. A 52-year-old man who underwent liver transplantation 3 weeks ago is maintained on immunosuppressive regimen to prevent the graft rejection. Lab studies shows an elevated BUN and creat compared to his baseline post-transplant values. This patient immunosuppressive medication most likely works via inhibition of which of the following cytokines? Amazing, guys. So this patient started on immunosuppressant medication, and after starting this immunosuppressant medication, he had nephrotoxicity, elevated BUN and creat. This is basically nephrotoxicity. So you should ask yourself, an immunosuppressant medication that can cause nephrotoxicity, He's talking about the calcineurin inhibitors. Because you know that the calcineurin inhibitors are the family of the immunosuppressants that can cause the nephrotoxicity. And how does the calcineurin inhibitors work? They inhibit a protein called the calcineurin, and when the calcineurin is inhibited, they will decrease the senses of the interleukin 2. And when the interleukin 2 senses is decreased, this will decrease the T cell proliferation, causing the immune suppression. Okay? So what are the members of the calcineurin inhibitors? We have the tacrolimus, and we have the cyclosporins. Okay? So be familiar that the cyclosporin also have a very specific side effect for its own, which is gingival hyperplasia. So it can cause nephrotoxicity because it's from the family of the calcineurin inhibitors, but it can also cause gingival hyperplasia. All right. And we also have two medications in the USMLE that can cause gingival hyperplasia: the phenytoin and calcium channel blockers. Amazing, guys. Phenytoin and the calcium channel blockers. Excellent. All right. A 64-year-old man with a 30 pack per year smoking history presenting with progressive exertional dyspnea and a dry cough over the past year. Pulmonary function test shows a restrictive pattern with reduced diffusing capacity. High CT scan of the chest reveals bilateral peripheral reticular opacities with honeycombing. Which cytokine is most responsible for this patient underlying pathology? First of all, what is this pathology? Excellent, Koshi. Amazing. Amazing, guys. So this patient is presenting with interstitial pulmonary fibrosis. He will tell you that we have an old patient presenting with progressive dry cough and dyspnea. And on auscultation, we heard inspiratory crackles. And on CT scan of the lung, we have the honeycomb appearance of the lung. Okay, so this is the presentation of interstitial pulmonary fibrosis. And what cytokine can cause or can mediate the fibrosis? The TGF-beta. So if he gives you whatever pathology and the pathophysiology of this pathology is fibrosis, the mediator for this fibrosis is the TGF-beta. Okay, guys? All right. A 58-year-old man presenting with fatigue and airless satiety. Physical examination reveals massive splenomegaly. Peripheral blood smear is shown. What are these cells, guys? What are these cells in the blood smear? Amazing. This is the teardrop cells. And this is the blood smear finding in patient with myelofibrosis, which is the fibrosis of the bone marrow. So when he asks you which cytokine is responsible for the presentation, what should you pick? Exactly the same, TGF-beta, because the pathophysiology of the myelofibrosis is fibrosis of the bone marrow. So which cytokine is mediating the fibrosis? The TGF-beta. Okay, and that's why on bone marrow biopsy in this patient, we will find dry tab, no bone marrow. Okay, and remember that the dry tab on bone marrow should point toward two conditions: the myelofibrosis and hairy cell leukemia. Both of them will have dry tab on bone marrow biopsy. Amazing, guys. A 26-year-old man with a history of frequent travel to rural areas presents with abdominal pain and diarrhea. Stool studies reveal ova and parasites. Which cytokine would most likely be increased in this patient? Amazing, guys. You guys are very smart. So here, this patient is having a parasitic infection. And how can the body fight the parasites, guys? We fight the parasite by secreting eosinophils. And which cytokine is responsible for increasing the eosinophil synthesis in the body? The interleukin 5. Okay, interleukin 5, exactly. Okay, so if he tells you that we have a patient presenting with asthma and we notice that this patient is having high IgE levels, which cytokine is responsible for the increase in the IgE level? Exactly, the interleukin 4. Okay, so the interleukin 4 for the IgE and the interleukin 5 for the eosinophils. And both of them are important for the allergy. All right, both of them are important for the allergy. Is this clear so far, guys? Amazing. All right, so this is our session for today. Before we end the session, let's go through a couple of questions from the Synapse QBank. Yeah, any fibrosis, exactly. So the keloids, for example, or even scleroderma, we will have TGF beta elevated. All right. So we have a 56-year-old woman coming to the physician because of 3 months history of progressive muscle weakness. She reports increasing difficulty rising from a seated position and reaching for items on the top shelf of her pantry. She also notes a new rash on her face and hands that worsen with sun exposure. Physical examination shows symmetric strengths in the deltoid and iliopsoas. There is a violaceous edema in the upper eyelid and the creatine kinase level is elevated. What is this condition? Yeah, so this is the classic presentation of dermatomyositis as we mentioned. And I told you guys, whenever you diagnose dermatomyositis, the best next step is to look for malignancy in this patient. Okay, amazing. All right, guys, so this is our session for today. Do you guys have any more questions? All right, thank you, everyone. And guys, for the table, the video will be posted on our YouTube channel. Okay, so you can check that in 2 days. All right. Thank you, everyone, and have a great day.